Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I'm Dr. Nariman Fahmi, a pediatric nephrologist. Today I'm going to discuss with you a very important subject. We find it in children, which is called nephrotic syndrome. In this picture we see a child. One of them is having periorbital swelling and the other one is the normal presentation. I put this picture so that we could remember that this disease is usually presented with edema, as we can see in this slide. What is the objectives of our lecture? Is to find out what do we mean by this disease, what is the pathogenesis, the pathophysiology of edema, clinical features, diagnosis, treatment, and prognosis. Definition of nephrotic syndrome is accumulation of symptoms and signs characterized by proteinuria, hypoproteinemia, edema, and hyperlipidemia. So, it is a syndrome, or we call it something that leads to other things. The first of all of the whole problem is finding a heavy protein in urine. Okay, this heavy protein in urine that cannot the liver compensate for formation of protein, so the blood protein will decrease, leading to hypoproteinemia. And because of the decrease of the albumin, which is one of the most important proteins that conserve our oncotic blood pressure, we will have transudation of fluid leading to edema, and I will discuss why lipids also is going to increase in this problem. The exact pathogenesis till now is really unknown. Okay? The exact thing that causes this heavy protein in urine, that causes this hypoproteinemia, edema, and all other consequences is till now unknown. But when they saw the evidence that these patients get benefit from steroids, from cytotoxic, they thought that there is an important role of the immune mechanism in this disease. And this helped in the future researches to find out how we can stop the problem so that it will not relapse in these patients. We can see in this small cartoon that on the one of the sides is the normal glomerular capillary, where the glomerular basement membrane is usually negatively charged and the protein inside is also negatively charged. So negative and negative, there will be repulsion of this protein and it will not pass through the glomerular basement membrane. But when the basement membrane has a defect, so that it will lose its, we can say, design and its electricity, the protein start to go through this membrane to the urine, forming a heavy protein urea. And this is a picture showing what will happen when we lose a large of a protein in urine. There will be a reduction of the albumin in the blood, and there will be a reduction of the oncotic pressure, and the fluid will go from intravascular to extravascular tissue to interstitium, and this causes to decrease in the blood volume in the intravascular, stimulating renin, angiotensin, aldosterone, and antidiuretic hormone system. All these causes edema, because as we know that sodium, aldosterone will lead to sodium retention, and antidiuretic hormone, it causes to decrease urine output and retention of water. All of these can cause the edema because of the also decrease in oncotic pressure and transudation of fluid. The liver actually start to increase its production of albumin to compensate the loss of proteins in urine, and with the increases production of albumin, there will be increase in other lipids, so lipoprotein carrier of triglyceride and cholesterol are all increased, so there will be hyperlipidemia. A classification of the disease. إحنا بالأطفال most common form is the primary or idiopathic form, but there is some children come from birth having nephrotic syndrome. This is called the congenital form. Idiopathic usually form 90% of the patients, but there is a small number that's secondary to SLE or diabetes or other vasculitis. So we have the three types of the disease. We are concentrating on the idiopathic or primary nephrotic. In children, usually starts the disease between 2 years and 8 years, or less than, we can say 5 years. And it's usually called a primary or null disease. Why we call it null? Null because there was nothing in light microscope when examining the biopsy from these patients. So when we try to take a small piece of tissue from the kidney of patients with idiopathic form, which we call it, we found 3 different problems in the tissue of these patients. Some of them called minimal change or null disease, which forms actually about more than 3/4 of the problem, 80%. And some patients having what we call mesangial proliferative, and others which is considered the worst scenario prognosis when the patient is having focal segmental glomerulosclerosis. So this is what we find it when took the patients with idiopathic nephrotic syndrome kidney tissue and see it under light microscope. البيشنتس usually قلنا يكون between 2 years and 6 years, and it is more common in male than females. The patient could have multiple episodes after remissions. These episodes are triggered with infection, minor infection, like common cold, rhinorrhea, fever, even worms infestation, or sometimes a stink, bee stink, يعني قرصة أو. Start after this to have increasing edema, increase in weight. There will be accumulation of fluid in any part of the body, in the pleura, in the ascites, lower limbs. Very rarely we can see there is a change in color or increase in the blood pressure, which we call it hypertension or hematuria. They are unusual presentation in the idiopathic form. Okay. طبعا الشيء اللي يخلي الفاميلي يخافون هو لما يستارت الأوديما مثل ما شفنا بالسلايد، نشوف عيونها مرمى، رجليها مرمى. This is striking the attention of the family so that they will go to the doctor for help. فنلاحظ in this picture شلون الأوديما بالأسايتس preorbital swelling and pitting edema on the dorsum of the foot. The first thing we are concentrating on is proteinuria. So the diagnosis depends mainly on this investigation. We take the urine dipstick, put it, we find appearance will be frothy, protein will be more than 2+ in urine. He will have sometimes pus cell or normal cast, but not RBC cast. It was called normal cast, Hyling cast. But when we collect the urine for 24 hours, we can see there will be a heavy, more than 1 gram per meter square per day. There will be protein in urine. Okay. By this, we can say that we have a problem of losing a heavy protein in urine, what is called nephrotic syndrome. Let's go back to we can find in the blood. We can see the albumin is low. The total protein will be decreased. This is the normal. Hypoalbuminemia means when it reaches less than 2.5 gram per liter, that means the patient is start to have edema. Okay. There will be increase in the lipids. Cholesterol will be increased. Other investigations, renal function, other complements or anything will be just fine, normal in this patient. Only heavy protein in urine, decrease of protein in the blood and albumin in the blood with mild increase in the lipids. Now the treatment, first of all, we should make the family a good education about the disease problem. They should understand what's going on. So we tell them as far as you give him low sodium diet, it is better for the child. It is better to restrict his fluid, and any infection that is going to happen or triggering the cause should be treated. These are the first three important steps: no added salt to the diet, fluid restriction, and treatment of infections. Diuretics usually, like hydrochlorothiazide or Lasix, are given to decrease the edema. But sometimes we have a very severe edema, which we call it anasarca. يعني الفلويد عيونه بطنه scrotal swelling, and there will be very few fluid in the intravascular. So when we are going to give diuretics, we are going to have no urine output at all. We have to increase the intravascular volume by, we call it IV administration of human albumin with furosemide or Lasix. This is a picture of the albumin. So the indication of this important drug is given in cases of shock or severe anasarca. Why we should not give it usually to the patients? Actually, it will be of no benefit, and it can cause many complications like volume overload, hypertension, heart failure, especially when we are giving it in a rapid infusion. So we should be careful when it's given to the patient. It should be slowly given to the child. The key drug treatment is the steroid. Steroid, as we know, has many side effects. So the steroid should be given in a specific way and decreased in a specific way. Is there an indication before we talk about the treatment about starting a steroid and its complication? Is there any rule for doing a biopsy to see whether it is minimal change or sclerosing that is causing damage to the kidney? Well, الانdications إذا قبل ما نبدي التريتمنت is فقط في الحالات اللي نعتقد أنه نستفاد منها إذا كان البيشنت عنده abnormal presentation like hematuria, hypertension, اجى البيشنت عنده high blood urea creatinine، الكومبلمنت مالته كان بيها low، أو الأيج مالته كلش قليل نعتقد هو congenital form، أو يكون الأيج مالته كلش أكبر من الاعتيادي. فبهذه الحالات ممكن يستفاد نسوي renal biopsy لأن يعطينا فكرة عن الدامج اللي موجود بالكدني والبروجنوسيس وإذا يحتاج treatment أقوى. الستيرويد نبدأ عادة 60 ملغ per meter square for 4 consecutive weeks، وأكو مصادر تقول up to 8 weeks، بس according to our إذا هو أكو response 4 weeks is fair enough. وحسب ما مذكور بالليترشر 90% will respond to this therapy. Now الدوز اللي بدينا بيها 60 ملغ should be then tapered to every other day as a single morning dose and gradually tapered later until we stop the treatment. So we should not continue on giving steroid for whole life. Alternate day steroids slowly tapered and discontinued over 2 to 3 months. If the patient is resistant to steroids, that means he's taking daily 60 mg per meter square with no response. At that time, this is called steroid resistant and needs biopsy performed to see what's happening inside the kidney. Many children with nephrotic syndrome will experience different relapse, at least one relapse. الريلابس يعني ورا ما صار remission واختفى البروتين in urine يرجع يصير عندي من جدة وجديد أوديما وبروتين يوريا. Because the exact problem and the disease is, as we said, could be change in the immunity. So anytime this immune could be affected. The course of the disease, remission means there is no protein or protein free in urine. Steroid resistance is when we are going to give full dose of steroid for a long period and there will be protein 2+ or greater in urine. This means it is resistant and need renal biopsy. And relapse يعني يرجع ورا ما صار عنده remission protein free يرجع عنده 3 pluses of protein in urine. Steroids has many side effects. فsometimes the patients نعتبرهم dependent when we are trying to decrease the dose of steroid to alternate day or 40 ملغ من 60 ملغ يرجع يصير عندنا البروتين والأوديما. فذول يبدي يصير عندهم cushingoid appearance with cataract, hypertension, growth failure, steroid side effect كلها ممكن تطلع على البيشنت مثل ما نشوف بهاي الصورة ومن ضمنها أيضا growth failure, stunted growth. This is very important. فبهيك حالة we should try to give another treatment for these patients. So بهاي الحالة مثل ما قلنا لازم نبدي another treatment واللي هي like cyclophosphamide, calcineurin inhibitors, mycophenolate. Sometimes they will give him only conservative management, and we can see there is a high dose of steroid methylprednisolone given only for 3 consecutive days, and then the kidney will have reached a stable state and we start to decrease the oral steroid gradually. فهذه بالنسبة للother options إذا كان البيشنت مالتنا لنشوف عنده بدأ side effect and he is going into resistance or dependent state. The most important complication of this problem is the infection because he's losing immunoglobulins and many types of proteins in urine. So infection could be in the abdomen, semi-peritonitis, يجي patient very having severe high fever, a tender abdomen, toxic illness. It needs to take peritoneal fluid for analysis, start for him third generation cephalosporins, broad spectrum antibiotics, and for anaerobic because streptococcal pneumonia is encapsulated microorganism. It is one of the most common important infectious agent, as I say, in the nephrotic syndrome infection. So we should put it always in our minds. البريتونيتس واحدة من أهم الكومبليكيشنز اللي تجي لنا الطفل يجي كلش تعبان يحتاج ناخذ مي من البريتون فلويد نسوي له culture sensitivity نبدي له broad spectrum antibiotics and continuous follow-up of his condition. Infection could be other parts of the body like UTI, cellulitis, meningitis, any part of the body could have infection. The other complication هو الembolic thromboembolic phenomena مثل يصير بالrenal vein thrombosis أو showering of the thrombi into the mesenteric veins, into the pulmonary, into the CNS. So this is لأنه sluggish blood flow بالintravascular, we should put it in mind to give him prophylactic antiplatelet or sometimes they give him for him anticoagulation إذا كان عنده very heavy proteinuria or very severe albumin loss. يعني الألبومين مالته إذا أقل من 2 أو باليورين ده يطلع أكثر من 10 غرامات بروتين فيحتاج له enoxaparin or warfarin and whatever. Hyperlipidemia should always give good instructions regarding the diet. Some studies say that anti-lipids or for يعني like simvastatin, atorvastatin is very important to be given to prevent the complication later in life of cardiovascular problems regarding the hyperlipidemia. إذا مثل ما قلنا الانفكشن like spontaneous bacterial peritonitis, pneumonia, cellulitis, urinary tract infection, sepsis, all are these complications of nephrotic syndrome. Prognosis, the good thing is that the patients, although have repeated relapses, many of them are steroid responsive. But those with steroid resistant, they will have poorer prognosis and they can develop progressive renal insufficiency. This is the problem in nephrotic patients. يعني أكثريتهم majority of them will respond and they have relapses, but those that not respond is having a poorer prognosis. At the end of the lecture, I wish you get the benefit and thank you very much